Okay, I think we can go ahead and get started and let people join as they come in the next few minutes. Welcome everybody to today's SGIM COVID Equity webinar series. My name is Renu Tiperneni and I'm one of the co-organizers of this series. Today we have a really outstanding webinar with an all-star lineup. The topic is health disparities among people with criminal justice involvement before, during, and beyond the COVID-19 pandemic. We have an all-star group of panelists, which include Alex Duncan, Homer Venters, and Emily Wong, who will be introduced shortly. We also have fantastic moderators with expertise in this area, including Tyler Winkleman, who's the co-director of the Health, Homelessness, and Criminal Justice Lab at Hennepin Healthcare, and Utsa Khatri, a fellow in the National Clinician Scholars Program at the University of Pennsylvania. As I mentioned, this webinar is part of a series that was developed over the last year that SGIM has put on through the Health Equity Commission. And we've focused on several topics related to equity during the COVID-19 pandemic. You can see a list of our past webinars here, which are all available on SGIM's Health Equity webinar web link, which is listed here. For those who are already in SJM, I think you know what a wonderful professional home it is. For others who are in the field of general medicine or interested in this field, I really encourage you to consider making SJM your professional home. It offers a welcoming and lifelong learning community, a road to professional advancement, and a voice for the future of healthcare, much like we're seeing today. I know that's at least it's been that for me. So if you're interested in learning more, you can also see at the bottom of this slide the link for membership to SJM. And with that, I will turn it over to Tyler and Utsa to lead us off in moderating.
All right, thank you, Renu. Let me pull up my slides. So thanks for joining us today. We are just, Utsa and I are thrilled to moderate this panel with three people who we really admire and have just so much respect for their work and what they've done in the field. So really looking forward to this discussion. Before we get started, I wanted to just briefly sort of go over terminology. I think for folks who are in the criminal justice and health space, this kind of comes as second nature. But I think it's really important to go over. So first, I think we all agree that using person-first language when we're talking about people who have histories of incarceration or have been impacted by the criminal justice system is really important. And so we try to avoid phrases that are really stigmatizing and labeling and try to use person-first language. For those of you less familiar with the criminal justice system, when we talk about jail, we're talking about a facility where sentences are less than a year. This can include people who are pretrial, so have not been convicted, may either be awaiting trial or just awaiting a first court hearing about whether they'll even be charged. Prison can be state or federal facilities, and these are for sentences over a year. Probation is a type of community supervision. It's generally an alternative to incarceration and usually occurs sort of after someone's been charged and convicted, but is in lieu of spending time in jail or prison. Within probation, there are varying levels of supervision. So in Hennepin County, where I'm at, they sort of have low supervision, which means basically you call someone every couple months, up to high supervision where you're checking in with a probation officer on a regular basis. And then there's parole, which is early release, generally from prison, and you have a parole officer that you're checking in with. And for both probation and parole, there are other types of requirements that people often have to meet in order to to stay in the community. So I try also to just provide some sense of sort of how people generally move through the criminal justice system, though this is certainly a simplistic picture. So someone is generally detained in a county jail or a city jail, and there's a few options from that point. They can be released, they can be detained, and have the option to be released with bail. If someone's not ultimately released, and they end up being sentenced for something, there's a few options. There could be no supervision, but there's a fine of some sort. There could be probation, a community supervision, or there could be incarceration. And that could take place in a jail or a prison. If it's in prison, you may spend time on parole after release from prison. And often if someone does not meet the requirements that a probation or parole officer has put in place or a judge has put in place, these can also lead to incarceration. And so over the last 10 years, parole and probation revocation have been increasing drivers of incarceration in the United States. And like I said, this is a relatively simplistic picture of how one might move through the criminal justice system, but gives you a sense that there's lots of different points along the way that can be fraught with structural racism, can exacerbate health disparities, and which are the key issues that we'll be discussing today. So, really, the pandemic has illuminated many of the longstanding challenges that people who are impacted by the criminal justice system have experienced. And I think many people, probably for the first time, started to learn about the overlap of public health and incarceration during the pandemic, when it became very clear that rates among people who are incarcerated with COVID and the staff that work there were substantially higher than rates of COVID in the community. And it became pretty clear that in most places, it was very difficult to adequately address this public health crisis through the structures currently in place in the criminal justice system. Partly because of this focus during the pandemic, and partly because of years and years of work and advocacy by many people, the health disparities that exist in the criminal justice system have received more attention, in addition to the long-standing and extreme racial disparities that exist in the criminal justice system, certainly in being just a couple blocks away from where the Chauvin trial is taking place, really, highlighted by the killing of George Floyd and many other African Americans. So today we're going to talk about sort of how these longstanding racial inequities overlap with the health disparities that we see in the criminal justice system. So with that, I'm going to turn it over to Utsa, and she's going to introduce our distinguished panelists today, and then we'll get started with remarks from our panelists.
Thanks so much, Tyler. Thanks for that introduction. I'm really excited to introduce our incredible group of panelists today. There's so much I could say about each of them, but to maximize our time learning from them today, I'm going to keep my introductions on the brief side. And we will be introducing them in the order in which we'll hear from them. So first we will hear from Dr. Emily Wong, who is a professor of medicine at the Yale School of Medicine and at the Chase Center for Health and Justice. Dr. Wong leads numerous research and advocacy efforts to identify legal, policy, and practice levers that can improve the health of individuals and communities impacted by mass incarceration. Dr. Wong is also the co-founder of the Transitions Clinic Network, where she practices as an internist caring for patients who are returning home after incarceration. Next, we will hear from Dr. Alexander Duncan, a senior officer at the Substance Use Prevention and Treatment Initiative at the Pew Charitable Trust. Dr. Duncan works on federal and state initiatives to reduce inappropriate use of prescription opioids and to increase access to evidence-based treatment for substance use disorders. Prior to joining Pew, Dr. Duncan, who has a doctorate in public health from Columbia University, worked as a researcher at Impact International and APT Associates. Finally, we will hear from Dr. Homer Ventures, a physician, epidemiologist, and former chief medical officer of the New York City Correctional Health Services. Dr. Ventures has recently been appointed to serve on the Biden-Harris COVID-19 Health Equity Task Force. Since April of 2020, he has focused on addressing COVID-19 responses in jails, prisons, and immigration detention facilities. He is also the author of Life and Death in Rikers Island. We have asked each of our presenters to cover a specific area within this topic for about 10 minutes. As you listen to their remarks, please type your questions in the chat and we'll address as many as we can after the panelists have presented. And with that, I turn it over to Dr. Wong.
Great, thank you so much. It's a real pleasure. There's no place that kind of feels more like home for me than being among internists and at SGIM talking about this with some of my favorite people in the world. I also see some of my favorite people in the world as participants and attendees, and there's expertise among us all. And so I was asked to discuss, give a broad overview, and I'll really kind of whip through this because again, I think that this is old news to all, but making certain that we're talking through things together using the same terms and kind of understanding the scale of what mass incarceration looks like and feels like in this day and age, what health disparities are among those that have criminal justice involvement. So here comes the awkward transition of going to slides, which I really almost didn't do, but decided to. Okay. Can you guys, I actually can't see anyone anymore, so I'm just trusting that everyone can see me.
We can see you.
Okay, great. So, what I wanted to do in my hopefully less than 10 minutes is to give a sense of the scale of the criminal legal system, and in particular to really kind of bring home this driving point is that there is disproportionate impact among racial and ethnic minorities and those who are of low socioeconomic status. And this is a grave, but you can't see my slides. Tyler, can you see it now?
We can't. No. If you want to,
I'll just talk.
Okay, sounds good.
Sorry about this. So my 3 points are threefold, is that we have incarcerated more people than any country in the world, disproportionately incarcerated racial and ethnic minorities. Secondly, that there are significant racial disparities within the criminal justice system. And these are in large part, I think, caused by the siloing, the intentional siloing of the correctional healthcare system from our community healthcare system, both in our policies, in our payment, and our intentional neglect of not actually providing the structures and resources to care for those who are incarcerated. And then thirdly, hopefully to highlight how internists have moved the needle forward in this work. If there's ever a time for internists to get involved, it's right here and right now. And so, you know, what my slides would have shown and why I was trying to do that is to really highlight some of the seminal research has all come from internists, general internists. And so just to start, there are 7 million individuals that are currently under the purview of the criminal justice system. This includes, as Tyler indicated, those that are incarcerated in prisons and jails currently incarcerated, and then those that are overseen. It's about 4 million that are in the community supervision system. All told, at any given time, there's about 10 million that move in and out of prisons and jails, and then about 20 million that cycle through probation and jail. So that's a large population of individuals at any given year. And then when you look at the expanse across the US over the past 3 years, it's over 60 million individuals have a criminal justice involvement, have been involved in, somehow supervised by the criminal legal system. So it's a big chunk of change of the US population. And it disproportionately impacts those of racial and ethnic minorities. And so a study that was published from 2003 and then repeated by the Sentencing Project shows that about 33% of Black men in this country in their lifetime will have been imprisoned. That doesn't include those that are in jail. We actually can't actually capture that because we don't have the denominators of who actually is incarcerated in the 5,000 plus correctional systems. But and this is, of course, far less than that that happens for white men, even Latino men. If you look at the incarceration of women, they are disproportionately also racial and ethnic minority groups of women are also disproportionately incarcerated compared to white women. They're a far smaller fraction of the population that's incarcerated, but they're one of the largest growing populations behind bars. And so, you know, in thinking about the disparities of chronic health conditions, there's a beautiful paper that was done by Ingrid Binswanger, again, taking data from where data exists. So in this case, taking self-reported data from the National Survey of Jails and the National Survey of Correctional Facilities, and then comparing that to data from the National Health interview study. And what she found was that across conditions, and this here includes high blood pressure, diabetes, obesity, so a BMI of greater than 30, heart attack, asthma, cervical cancer, and hepatitis, all those conditions are greater among those that are in prison as well as in jail compared to the general population. And this is after you adjust for age, gender, education, US is your birthplace, marital status, even alcohol. You know, the studies also adjust for race. And, you know, in that time, I don't think our conversations about adjustments for race were as nuanced, but certainly trying to tease out how it is that incarceration might be independent of the structural racism that exists and that's baked into the health system. Again, they adjusted for race and found that still individuals that have been incarcerated either in jail or prison have higher rates of those chronic health conditions. Laura Hawks, who I think is on this call, subsequently has looked also in probation, for instance. And so among those that have never been incarcerated, but just under the purview of the criminal legal system, also found using a national population-based study, and again, it's all self-reported data, similar trends. So finding that in, for instance, hepatitis is at increased prevalence. People that have been on probation or are currently on probation have increased odds of hepatitis. And so the point is that when you look across health conditions, and then certainly if you look at mental health and substance use disorders, those who are incarcerated are disproportionately affected by health, have disproportionately higher rates of these chronic health conditions compared with the general population. Some of what I think is particularly important to note about these studies is that there is a constitutional guarantee to healthcare when you're incarcerated. This was guaranteed by a Supreme Court case in the 1970s, and then subsequent court cases have reinforced different constitutional guarantees behind bars. And so what that means for this young, typically poor, and disproportionately Black and Latino group of individuals is that they actually access healthcare for the first time behind bars. It's about 40% of individuals are newly diagnosed with a chronic health condition when they're incarcerated. And so their experience of their healthcare as an adult is first defined by that interaction. Their understanding of their disease, how they manage that chronic health condition, is dictated by how correctional health care is like. Homer, I think, is going to give us more insights into what the practice of healthcare behind bars is. And so I'll leave this as to say is that I've had many patients describe to me in my primary care practice how they've never, ever learned how to take a medication. They don't keep their medications on self, never have drawn up insulin, never have used a glucometer. In many settings within correctional systems, people, in order to actually get access to healthcare, they have to fill out a slip. The slip is first adjudicated by a non-medical staff, first a correctional officer. And then after that, once that adjudication is made, then it goes to a nurse, and then it goes to a physician. And so the whole notion of how it is that you can kind of be an activated patient, develop self-efficacy, manage your own chronic conditions, actually get access to healthcare is totally and completely different for this population. And again, I said millions pass through the correctional system than those that have never passed through the correctional system. And then, of course, when people come home, our expectations of what they have to do within our correction system is totally different. People come home, and it's 95% of those who are incarcerated will ultimately come back home to the correctional, to our community health system. And they're often released without medications, or with a short supply of medications. Again, Tyler's group has done a beautiful study that was published last year in JGIM, which showed that, unlike when we request records from the healthcare system behind bars, and that actually can be quite difficult and can be challenging, and we actually may be charged, patients in certain states either can never, they're prohibited in Louisiana from getting their medical records, or have to pay hundreds of dollars to get their medical records. And so there's many different ways that there's significant barriers just to that basic transition of healthcare once people are released from correctional healthcare system. And then, of course, when they come in to primary care, often they come without insurance if they're living in a non-expansion state. And so in states that haven't expanded Medicaid, typically present significant barriers to getting their primary care, getting a transition if they're on medications for opioid use disorder back into some system that treats their opioid use disorder and mental health. And so it's in this setting that you have this huge population of individuals that move in and out of two totally siloed healthcare systems that aren't financed the same way, that aren't linked the same way. Most internists actually don't know that there's a whole correctional healthcare system behind bars and don't know how to navigate that. And in this, creates significant barriers to their healthy transition. And not surprisingly, poor health outcomes. And so, where I would state is that the studies actually that have been conducted, again, much of the work has been done by internists. I see Ben Howell on here, have shown that there's a worsening of chronic health conditions. So high blood pressure gets worse when you're released. It's actually better managed when you're incarcerated. HIV outcomes are worse when you're released to the community. And then hospitalizations are increased, as well as the high rates of death. You guys all know the seminal study that was published again by Ingrid Binswanger in 2007 that shows that, again, in Washington state, and then this has been subsequently replicated in other states in the US, the people have a disproportionately high, like 12 times increased risk of dying, even in the first 2 weeks post-release. And they're all for preventable conditions, mostly for overdose, which we can prevent, for heart disease, for suicide, and then for cancer. And so there's much room for us as physicians, especially as internists, to get into this business of understanding how it is that we have to improve the care for people that move in and out of the criminal justice system. And I think I'll end there by just saying that, you know, as a community of internists, we are obsessed, rightly so, with really thinking about how it is that we advance health equity. Oftentimes, though, I've personally, in my own experience, have found that where we're not getting our feet wet is deep into this whole other functioning healthcare system behind bars, that we're able to talk about other social needs, but rarely think about how it is that we screen for incarceration, how it is that we train our trainees to get in behind bars and understand the real health needs and what the practice of healthcare is behind bars. And thus, without doing so, I think it's impossible for us to really advance health equity in a way that we think really will move the needle on the deepest of racial disparities in this country. So I'll end my comments there, and sorry to not have got my slides to work.
That was fantastic. Thank you so much, Emily, for providing such a comprehensive overview of a really complicated topic. You had mentioned some of the policy barriers that exist among many other types of barriers. And so with that, we're going to hear from Dr. Duncan specifically on some of the relevant policies. Dr. Duncan?
Great, thanks so much. So I'm glad Dr. Wong mentioned overdose and Medicaid, because those are two things that I'm gonna touch on that are really important for the work that I do from the opioid use disorder perspective and from the policy perspective. So this is what I'll cover today. Just a little bit of background on the Pew Charitable Trust. Pew is a nonprofit, nonpartisan research and policy organization with a mission to help states identify evidence-based solutions to pressing public policy problems. Pew works on a broad range of issues from state fiscal health to public health. And my team, the Substance Use Prevention and Treatment Initiative, is focused on helping states increase access to high quality, timely, comprehensive, and evidence-based OUD treatment. And much of my work is at the intersection of opioid use disorder and criminal justice. I want to first ground my comments in what we all know is the racialization and criminalization of drug use. As such, the policies to address substance use and to increase access to services will affect communities differently. What we now think of illegal drugs weren't always illegal and were marketed to middle-class white women. But we start seeing a shift with racism being on full display. The opium wars with the British and Chinese of the mid-1800s were about money and control, but surely had a racial tinge, and then followed a host of laws in the US to control substance use leading up to the war on drugs. But let's switch from history to talk about a little bit about policy and how policy can be helpful for OUD treatment. Medicaid is one of the largest payers of OUD treatment and is a major stakeholder in advancing OUD treatment policy. Medicaid was established in 1965 and is jointly funded by the federal, state, and local governments, with states administering the program with assistance from the local jurisdictions. As you can see on the screen, Medicaid and CHIP are among the largest public insurers, covering 71 million, with Medicaid itself covering more than 64 million. Here's the racial and ethnic breakdown using the data labels from the data source. As you can see, 20% Black, 29% Hispanic, but I want us to keep that in mind when we start talking about Medicaid and incarceration. So let's talk about how Medicaid works when people are incarcerated. So Medicaid eligibility differs by state, and in most states with Medicaid expansion, people who are incarcerated would be eligible. For those of you who practice in prisons and jails, you know that just about all of your patients are eligible for Medicaid. And people who are incarcerated are disproportionately low income and people of color. As you can see on the screen, people who are incarcerated have much lower annual incomes than people who are in the community, with some clear racial and ethnic and gender differences. And there's a long history of discrimination and racism as to why there's a disproportionate number of people of color who are incarcerated, particularly for drug-related offense. Given this long history of disproportionately incarcerating people of color, we have to think about what does that mean for the health of people of color, for the health of people of color who are incarcerated, for the health of people who are leaving incarceration who are Medicaid eligible, and in particular, what about the health of people of color who are leaving incarceration in non-Medicaid expansion states? Dr. Wong already described the health needs of this population. So all I'm gonna add is that the COVID-19 pandemic has challenged prisons and jail budgets, with facilities providing their regular health services in addition to pandemic-related care. Unfortunately, even with these budget challenges, federal law does not permit Medicaid billing for health services provided to individuals who are incarcerated unless that patient has a hospital stay of at least 24 hours. And the reason why Medicaid can't be billed is because of a section of the Social Security Act. The act does not allow for continuation of federal benefits such as Medicaid, Medicare, and CHIP for individuals who are incarcerated. Several organizations are lobbying to change this. The National Association of Counties and the National Sheriff's Association have a report addressing the federal Medicaid inmate exclusion policy, which mentions several recommendations for policymakers, but most notably to amend a section of the Social Security Act to allow for the continuation of these benefits for individuals who are detained pre-trial. And this will benefit jails since jails house individuals pre-trial, and if amended, will assist jails in paying for the health services for individuals that are eligible for these types of insurance coverage. There are so many bills that I could mention, but I want to mention one on this topic that was introduced in the 116th Congress that was reintroduced in the current 117th Congress. That's the Medicaid Re-Entry Act that's sponsored by Tonko in the House, which calls for allowing Medicaid payment for medical services provided to individuals who are incarcerated during the 30-day period preceding the individual's release. In the 116th Congress, this bill was included in the HEROES bill, one of the COVID-19 stimulus bills. The HEROES bill passed the House, and changes to the Medicaid Re-Entry Act portion stalled in the Senate. Representative Tonko reintroduced the Medicaid Re-Entry Act on February 8, 2021. This language was also included in the American Rescue Plan Act of 2021, which passed the House at the end of February, but this part was removed in the Senate due to the Byrd Rule, which means that everything in the bill must be related to its original purpose. Since this was not about COVID, it was removed, but this will come back up during bill reconciliation. But HR 955 is still alive and can move separately. States are also taking things into their own hands and not waiting for Congress. Section 1115 demonstration and waiver authorities are vehicles to test new and exciting ways to deliver and pay for health services in Medicaid and CHIP. Medicaid waivers are a potential avenue to pay for jail and prison-based healthcare services, none of which are currently reimbursable because of federal rules. Let me give you a few examples of states trying this mechanism, and more states are considering submitting these waivers. Prior to the COVID-19 pandemic in 2019, New York submitted an 1115 waiver to request to CMS to authorize federal matching funds in order to provide select Medicaid services, including opioid use disorder treatment, in the 30 days pre-release from incarceration. This waiver decision is still pending. Utah submitted a request at the end of June 2020. The request is to make those incarcerated in jails eligible for Medicaid 30 days pre-release. This waiver decision is also still pending. In November 2020, Kentucky submitted an 1115 waiver to allow Medicaid funds to cover substance use disorder treatment in state and county correctional facilities and to transition the incarcerated enrollee to an MCO 30 days prior to release to ensure continuity of care. This waiver decision is also still pending. We're hearing the reason for the delay is that CMS is trying to figure out standards of care behind bars, so Medicaid isn't paying for substandard care. And I learned on a webinar this morning that Massachusetts Medicaid agency has a pilot program to reactivate Medicaid 30 days prior to release. For other federal legislation, there's a ton I could mention that's not Medicaid related. We can't talk about it all, so I just want to mention two things. The Crisis Stabilization and Community Reentry Act of 2020 by Senator Cornyn out of Texas became law at the end of last year. This law permits the Attorney General to make grants to organizations that will provide clinical and criminal justice reentry services to individuals with serious mental illness and substance use disorders. One thing to note about this bill, it specifically calls out long-acting injectable medications. Last year, Senators Portman, Klobuchar, and Whitehouse sponsored the Comprehensive Addiction and Recovery Act. Pew thinks that the 2.0 version of this bill will be introduced in the 117th Congress in March of 2021. And this bill is packed with substance use disorder and criminal justice related provisions. It authorizes $50 million annually at the Department of Justice to issue grants to states or local governments to develop, implement, or expand programs to provide all forms of medications for opioid use disorder to individuals who are incarcerated and for correctional facilities to plan for the continuity of care post-release. There are several COVID-19 telehealth flexibilities, but most aren't applicable to individuals who are incarcerated. So I just want to focus on a few things. The HHS Public Health Emergency Declaration was declared January 31st, 2020. The initial declaration allowed for the use of telemedicine, audiovisual real-time communication for new buprenorphine patients. On March 31st, 2020, the DEA allowed further flexibility by authorizing practitioners to prescribe buprenorphine to new and existing patients with opioid use disorder via telephone without an in-person or audiovisual visit. This includes prison and jail practitioners. Under the public health emergency, healthcare providers can now use any non-public facing remote communication product like FaceTime or Skype to communicate with patients, which was not previously allowed because of HIPAA. Of course, this only works if patients have access to a telephone and a private place to have a conversation with a medical provider, and many smaller correctional facilities struggle with telehealth infrastructure. Broadband access is surely a problem in the community, with at least 21 million lacking access, and may be challenging for rural correctional facilities. Audiovisual telehealth is not widely available due to structural, racial, and economic inequities, inadequate broadband and internet infrastructure, low digital literacy, and health system barriers, which also may not be accessible to people with disabilities, including people who may be deaf, which is why it's important that telehealth services can be provided via telephone only. And Pew funded a report written by George Washington University on telehealth flexibilities for OUD treatment. The report was recently released on February 23rd. The take-home message from the report is that the DEA and SAMHSA have the legal authority to extend these flexibilities without authorization from Congress. And I want to spend my last few seconds talking about the X waiver. The X waiver is an important issue to Pew because we believe that elimination of the X waiver will increase access to treatment availability. The X waiver is relevant for prison and jail clinical providers since you must also have a waiver for OUD treatment. And I want to mention a particular challenge that prisons and jails face with respect to the X waiver. Currently, providers are in qualified practice settings can immediately treat up to 100 patients concurrently, up from the typical 30, but prisons and jails do not qualify as qualified practice setting because they don't accept third-party payments for health services or federal benefits. This is a barrier for larger jails who may be treating a large number of people. On the screen, you'll see two press releases. One was about the Trump administration proposing to ease buprenorphine waiver rules. They were never implemented. And currently, the Biden administration is seeking to come up with some similar regulations. We hear that they are working with several agencies to do so. And then there's the Mainstreaming Addiction Treatment Act, also known as the MAT Act, that was recently reintroduced by Senator Tonko on February 25th, 2021. So with that, I will stop here and I look forward to the discussion.
Thank you, Dr. Duncan. That was an a wonderful overview, and I think really highlighted some of the policy challenges to providing adequate care in jails and prisons, and some of the policy levers that are available. And so now I want to turn it over to Dr. Venters, who's going to sort of focus on some of the clinical complexities and operational challenges that have to be overcome to provide quality care in jails and prisons. So I will turn it over to you, Dr. Venters.
Thank you. So hello, thank you for the invitation. Thanks for the organizers, fantastic moderators, and the other panelists, and also the attendees. I see a lot of, I think I just accidentally texted a friend to everybody, but it's nice to see everybody, and also to be back with SGIM. I haven't been in an SGIM forum for a while, so thank you. So yeah, my name is Homer Venters. I've worked in correctional health for my career. I should first say that my comments and remarks don't reflect the recommendations of the Biden-Harris Task Force on COVID-19 health equity. We've heard a lot, great overviews, both of the general terrain and also of some of the specific policy issues around OUD and access to MAT and other treatments. So I'll try and build on those things. One of the things I wanted to call out at the beginning is that we often think of correctional health or healthcare for people who have justice involvement in terms of the problems that individuals have and the health outcomes that they have. And that's certainly important because we built this system of mass incarceration based on kind of a white supremacy construct that has steered people into these places, people of color, people with behavioral health problems, people who are poor. But I think it's really critical for us to stop and consider the health risks that these places confer to the people that are in them. So we have about 5,000 jails and prisons, a couple thousand juvenile detention settings in this country. These places confer risks of morbidity and mortality to the people that are in them on a systematic basis, risks that contribute to their worsening of illness, acquiring new illness, and dying. You know, the leading cause of death we talk about routinely in American jails is suicide. Many of those suicides are potentiated by this very common practice of when somebody has a mental health crisis, throwing them in a solitary confinement cell. And so I'll talk a little bit about that actual scenario as a way to kind of highlight the health risks of incarceration itself, not simply the health profiles of the people that we happen to incarcerate, because there's a profound interaction that occurs that we usually sweep under the rug. And the net result of that is to absolve these institutions of causing sickness and death. And you know, that's by design. These are systems that are operating as designed. One of the things that is really also, I think, important to call out is that most of the health structures that we rely on in the community to promote evidence-based healthcare, to promote evidence-based quality assurance, quality improvement, to look back at sentinel events, most of those structures are absent or AWOL when it comes to healthcare behind bars. So if we look at jails and prisons, most of the healthcare is provided under the authority of the security service. So if you are the head doctor or head nurse, your boss in most of these 5,000 jails and prisons in this country, your boss is actually the warden or the sheriff or somebody who's a security person. We don't have independent health authorities, except for in a handful of places. I was fortunate to be the chief medical officer in New York City Correctional Health Service. There, you know, my boss was the commissioner of health, was one of the commissioners of the city of New York. This is a model that's more common in Europe, but is not common at all in the United States. And that is crucial because, for instance, if we think about these 1115 waivers, if we think about what is certainly a very virtuous endeavor, which is to provide funding and access to evidence-based opiate use disorder treatment as people are, you know, going through county jails, for instance, and certainly we should do the same thing in prisons. I have real reservations about handing over boatloads of Medicaid funds to sheriffs, which is exactly what we would do in a lot of these situations, because these are not independent health services. These are, for instance, in jails, mostly for-profit staffing companies that work for a sheriff or work for a Department of Correction. And so the structure of these health setups or health organizations, it's not just that the CDC and our state departments of health are not usually involved in assessing the quality of care or the adequacy of care. It's that the people who really set the guideposts, who make the decisions about what's quality care, what's not quality care, those are often security folks. And so if you look at, for instance, MAT around the country, you can see that there have been many decisions made by security folks about, we want this brand of MAT, not that brand of MAT. And that is, through very effective communications and sales by pharma, less effective advocacy by us in public health. We're always like 50 steps behind. And sheriffs responding to what they think are the security issues. But what happens is the welfare of the patients it can be second or third priority in a lot of the circumstances. Going back to this notion, the scenario I mentioned about what happens when somebody has a mental health crisis. We had a really great, the Department of Justice does a lot of investigations about civil rights violations in correctional settings in the country. They're called CRIPA investigations. And so I work as an expert with them. And we had a case we worked on in a major state DOC, Massachusetts, where we looked at the practice of solitary confinement, but particularly how solitary was being used as a primary response to a mental health crisis, except for in the new era of kind of solitary reform, it had a new name. It's called Mental Health Watch. And the staff there would say that they do a lot of things besides simply locking somebody behind a door. But what the Department of Justice found was that this was a constitutional violation. This is really an important new finding, that the Department of Justice found that the practice of taking somebody who's suicidal, locking them behind a door, keeping them further away from engagement in care was a violation of their constitutional rights. Now, what is so telling about this is that it's a law enforcement agency investigating another law enforcement agency, but it's all about health. And so where are the health leaders? Where are the public health structures? Where's the CDC, for God's sakes, to say, like, you can't do this, or we're going to surveil all the practices in jails and prisons that impact health. Another example I invoke quite a bit is traumatic brain injury. When I was at the city jails in New York City, we did a lot of work to identify and report out injuries. And we would often find that we had nothing to compare ourselves to. There wasn't a standard approach to reporting injuries. But we found alarming rates of traumatic brain injury among our own patients. There was a very high prevalence for the people showing up. We would do screenings. There's also a very high incidence of new TBI occurring in our jail setting. But if you went and looked at all of the work that the CDC does on preventing, educating around traumatic brain injury, let's say in youth sports, you won't find any mention of people who are behind bars, people disproportionately of color, people with behavioral health problems also. And that, I think, is one of the single easiest to grab onto examples of racism in health, right? The clinical problem is there behind bars. And as a matter of fact, I think it's there behind bars in greater, higher prevalence. But we don't talk about it with our community health structures. We talk about it maybe in some hidden conversations or some special seminars. And so I think that I'll just kind of end up with a couple of problems, that one of which I think has already been invoked, which is the engagement of our patients that we care for behind bars. Their engagement with health service is really impacted. And it's not just because they have criminal cases and they have lots of stress in their lives. Often, I've seen this in doing the COVID work, often the person who's going to come talk to, or the service that's going to come talk to people about a COVID vaccine, that's the same service that may have turned a blind eye to you getting beaten. It may be the same service that said it's okay for you to go into solitary confinement. This practice of solitary confinement is uniquely American in jails and prisons. It's often health staff that give a stamp of approval to that practice. And so the engagement of our patients after incarceration really can be so deeply fractured because they've learned to rightly mistrust health staff in a lot of cases. And then the final thing I'll mention is this really unspoken issue of dual loyalty. The idea that as health professionals, our mission to our patients is, corroded and eroded and sometimes fractured because of the pressure of all these security mandates. And that, I really analogize it to infection control in that it doesn't mean, like, we know that there are germs everywhere. Dual loyalty is everywhere in correctional health. And it doesn't mean, I don't think, that the presence of dual loyalty means we're going to violate the rights of our patients. But we never talk about it. We certainly never go look for it in a structured way or train our staff to mitigate the impact. And so I think that it remains a frontier that we have to even learn to talk about and address. But to the extent that we all agree that the people that are incarcerated are, disproportionately people of color, disproportionately people who are poor and people with behavioral health problems, it means that these unaddressed problems of the structures and the barriers to healthcare fall on them. And so it's really to us as physicians to, start calling them out more effectively, engage with people, as Dr. Wong said, who work on the inside to learn about them, and then engage laterally to our colleagues in policy and public health to be much more effective on behalf of our patients. So I'll stop there, but I'm certainly thrilled to be part of this great discussion.
Thanks so much, Dr. Venters. For most of us who work in the community, we know so little and learn so little about the healthcare that's provided behind bars. And so for many patients, that's decades of their life. And really thank you for sharing your unique insight that you have from your experiences. The last portion of this before we open it up to the Q&A, I wanted to pose the same question to all three of our panelists, and we'll go in the same order that they initially presented. But as Tyler kind of alluded to in the beginning remarks, the events of the last year, specifically the COVID-19 pandemic, and then the country's awakening to the pervasiveness of structural racism after the killing of Mr. George Floyd, has brought this issue and the healthcare of justice-involved populations to the national conversation for the first time, really. So given this shift, I'd love to hear what each of the panelists think about what changes might facilitate meaningful and sustained improvements of the health and healthcare of this population. And what do you fear will continue to serve as barriers for real change? Dr. Wong, we'll start with you.
I had some time to think about this, and part of what I very much appreciated about both Dr. Duncan and Dr. Venter's comments is how deeply structural and ingrained and challenged these are. The problems aren't the patients, the problems aren't the families, the problems aren't the communities, it's the bars themselves. It's, the history that we have and the ways that we've enabled these policies, sometimes knowingly and sometimes unknowingly, and that's how structural racism works, is that layers upon layers upon layers, and there's almost no way to dig out, certainly at the patient's level. And so, I think core, and this may seem so pie in the sky, but I think it's the deepest part of the issues, is that we have to bring people with histories of incarceration into our clinic spaces as community health workers, into our researchers as people that are eyes wide open, see how it is that we're studying, into thinking about the policies to advocate for, that if it's people like me that are kind of, pushing forward, all is lost to unearth this, at structures like Yale, institutions like Yale, at Yale New Haven Hospital, that we have to really deeply think about who it is that we have at the table, how it is that we have them at the table, and then really unearth and bring that down. And so I personally think that that's one big issue that, through Transitions Clinic Network, we've had community health workers that have histories of incarceration into the clinic space, and they're all people that have criminal records and have been incarcerated. And it's in the undoing that we start seeing more clearly the places where my practices, our practice, the institution's practices are racist, that challenge in a trusting space where we can start bringing patients in. The second thing I think that's really important is this siloing, and I alluded to it before, which is that if we don't have a system that is transparent, if we don't have ways of really measuring the quality, the absence of data on the care that's provided inside, the absence of kind of the separation of loyalty so that correctional healthcare systems are overseen by health professionals. In that absence, the absence of kind of a payment program that at least enables a continuity of care, this is a structurally violent system that then, of course, creates and perpetuates the grave disparities that the system is meant to create. And so until we attend to these big structural issues, what we do as doctors, I think, is important as an internist. I don't want to minimize it, but we won't be able to move the needle. It's actually, it's not an individual level issue.
Thank you. Go ahead, Dr. Duncan.
Yeah, I mean, of course, I fully agree with Dr. Wong. Of course, more upstream solutions are needed. We spend a lot of time and effort putting out fires, but not blowing out the match. And work is needed on both ends. From a policy perspective, we really have to ask ourselves, are we willing to put policies in place to reduce racism? And what do those policies look like? And those policies go far beyond the scope of this conversation. Pew does a lot of work on correctional issues through our Public Safety and Performance Project, and that team can speak more intelligently about general criminal justice policies. But I think we should really be thinking about some additional policies that have reduced the jail census recently, and some jurisdictions are eliminating cash bail. These policies are a step in the right direction, but we have to think about unintended consequences too, with the cost of at-home monitoring, for which the court now wants supervisions for these individuals. And we must ensure that the supervision matches the alleged crime and that the cost of supervision is equitable. And I also want to touch on another point that Dr. Wong mentioned, because I fully agree. Unfortunately, prisons and jails become people's regular source of healthcare. And as such, we want correctional healthcare to be as robust as possible. And in terms of kind of thinking ahead and what could meaningful improvements look like, some of the policies I mentioned have the potential to affect change, but these policies will affect communities differently. For example, Medicaid reimbursement for services provided while people are incarcerated has the potential to ease the financial burden on correctional facilities, with the hope that care will improve for some individuals. Of course, that's the hope, but without care standards, we can't be sure how things will really play out. And one thing that I fear is that it'll take a long time to sort out the details of Medicaid reimbursement, while the disproportionate number of people of color within these facilities will continue to suffer and not receive enhanced services.
Thank you. Dr. Venture, same questions. What are you hopeful about in terms of meaningful structural change, and what do you think will continue to serve as barriers?
Sure. I think that, these are profound barriers. I think that jails and prisons and immigration detention settings, to a lesser extent, have devolved for decades, for a long, long time. And they're not, I don't think it's quite correct to think of them as like the Keystone Cops or incompetent, because they're quite competent to things they care about. If you think about how nuanced, for instance, the assessments are about minimizing the health and mental health services somebody receives in state prisons, that's designed, and those classification systems are incredibly nuanced, so that they spend the least amount of money on people as possible, the least amount of programs. So very sophisticated systems, but they're not focused on promoting health. And I think it will take a long time to make really fundamental changes. I do spend a lot of my time now focused on how to leverage what we're doing with COVID. I've done about 25 court-ordered COVID inspections of jails, prisons, and immigration detention settings. And what's clear is we have, for a brief fleeting moment, the interest of the CDC. The CDC put out guidelines on how to respond to COVID in correctional settings back in March, and it's been updating them. State departments of health have been platooned unwillingly into this area of like testing and now vaccination. And so these public health structures, I think what we need to do is figure out how to keep them there so that we can not only put out guidelines, which the CDC did, but the CDC should be out measuring who's following those guidelines. Is there an adequate approach to following just those guidelines? And then how do we take one or two steps further? Because as Dr. Duncan said, this notion of bringing in higher levels of funding does have real promise. However, these are systems that have worked very hard to elude any sort of transparency. If you look at what happens to a person when they die behind bars, usually the only real assessment of whether or not there was adequate care or whether or not what was supposed to happen comes when an ME or a coroner does an autopsy. So you don't have a robust sense of did they receive a quality community standard of care or even a correctional standard of care, or did anything that happened behind bars contribute to the death? We haven't even done that with COVID deaths. So we need to do that we need a real independent investigation of COVID deaths behind bars. But much more broadly, we need to leverage this moment where we have this fleeting interest or attention from the CDC and state departments of health to keep them there and build much more evidence-based approach to thinking about what are the quality approaches to healthcare and what are the health risks that people experience when they go to these places.
I just was going to add one thing. This has come up in a bunch of conversations. I've been thinking about this kind of unique time we're in, and also a unique interest in correctional systems. And it's many of us have been working at this for a decade now, and this is kind of the most amped that people have gotten around decarceration. What it looks like actively to get people home and out of correctional facilities where they're less out of harm's way. And to me, I think a real kind of challenge, like at the crux of who we are as internists, is really thinking about how it is that a person comes home from a correctional facility, that if we're going to decarcerate, and as Dr. Venters has described, the conditions inside, how challenged they are, how understandably mistrustful they are as an individual to come into our health system. Are we as health system leaders and as internists prepared to think about, what it takes to bring those individuals into our health system, to engender trust for the first time? And, I think if we think deeply about our health systems, they're really not set up to do that. I think especially our young learners, but all of us that are advocates and thinking about decarceration, and you can go rah and get the medications for opioid use disorder and get them, all these kinds of evidence-based things inside. But if we don't as internists bring them home into the community, so much of what is the promise of decarceration, that when people come home, is lost. And so I don't know. I think that's I think about that tension in medicine and how it is that we've learned to practice and how it is our health system creates these barriers. And that's a big fear of mine. You asked about kind of the fears. In the spaces where we practice, it doesn't often create kind of the latitude that we need to really kind of think about how you undo the harm at even the individual level, much less at the policy level.
All right, we're going to open up the floor to questions. So if you have a question, please feel free to put it in the Q&A. I'm going to kick us off here. So all of you touched on this a bit in your remarks. And I'd love to hear how you think about balancing the need to have oversight of correctional health services lie within the healthcare sector and provide quality care, with the need to sort of fundamentally change the scale and inequity of the criminal justice system. And either in your own work or say at a state or federal level, how should we be balancing sort of making correctional healthcare as good as it can be, while also realizing that it's operating within a system that is inherently unjust?
I can provide like a quick response. I think I think these are principles that are in service of each other. I don't think they exclude each other or work against each other. The notion that we need to have access to evidence-based care for people who are incarcerated and the need to undo mass incarceration in our country, and the kind of racism that drives both the inadequate care and also the mass incarceration. I'll go back to solitary confinement as an example. We, back in 2014 or 13, started to document with regression analysis the profound association between self-harm, physical self-harm, and exposure to solitary confinement. And as we did that and then built the case for eliminating solitary confinement by and large in the New York City jails, we also then built alternative units. And then when we published both the data about the harms and then also the solutions, probably the most important part of those publications was the costs involved, and showing that even to build an evidence-based approach to treatment for serious mental illness in a jail setting, each unit costs about $2 million more a year than a regular unit. And that was really predominantly by loading up staff because you need access to treatment. And so the take home really was, you really shouldn't be putting people with serious mental illness in a jail setting, right? Everything about treatment is cheaper and more effective when it's somewhere else. But it's the kind of cautionary tale. And so my approach really has been to first get honest about the health risks, about what's happening and the costs of what's happening, and then use that as leverage both to say this is what the evidence-based care should be, but also to say this is what policymakers need to see as they're rethinking their policy decisions. And I'd love to hear what the other two also experts have to say.
Yeah, I just want to mention, a couple of things. One, with decarceration, COVID has shown us that correctional facilities can be decarcerated. So that's something that kind of we just need to be thinking about, that there are ways that we can bring people back to the community. We do need to make sure that there are reentry supports surrounding individuals who are leaving. It is not okay just to, let people leave without any healthcare and social services. So that's the first point I want to make with respect to the entire system. With respect to the healthcare system, there are great advantages to having a healthcare system that is in the community that also works within the correctional facility. The organization that Dr. Winkleman works for, there are clear advantages to having your jail clinician also being your community clinician. People will be like, oh, I know Dr. Winkleman from the facility. It helps create a place for patients to feel more comfortable. It also creates efficiencies with being able to understand that person's medical history, shared medical records. This happens with Dr. Winkleman's organization, the Denver City and County Healthcare, Denver Health that provides services to the Denver City and County jails also has a similar makeup. So there are advantages that we can take from several correctional facilities and put them into practice. Not that I'm saying one is better than the other. I'm just saying that there are advantages for this type of correctional healthcare system.
Dr. Wong, anything that you want to add?
No, I think that they answered. I mean, I just don't think one is in opposition to another. I mean, there's many complexities of how we practice and how we practice medicine. And I think these two things can be both true at once, is that you can, simultaneously push for decarceration as you recognize that some people are going to be inside, and so you vaccinate at the same time. Is that you can move forward with different policy and different programming and different structures when acknowledging that these are, again, It took 40 years to build up this system of mass incarceration. It won't go away overnight. And there's real people, families, and communities that are touched every darn day. And so the ways of lifting up and building up the healthcare systems behind bars, I think, is in service and is part of the process of decarceration.
Thanks for sharing that. We have a question in the chat from Dr. Justin Burke. He asks, how do you get buy-in for alternative uses of restrictive housing, particularly without political interest in investing in new housing units? This has been a challenge in Rhode Island.
I'm thinking Homer should take that. So,
and I'm taking this as restrictive housing, as in restrictive housing inside a jail or a prison. So places, isolation, solitary confinement, punitive or administrative segregation. So if this general term of places where people are put either to be punished, which is usually called disciplinary segregation, or because they're thought to be dangerous or there's some sort of security issue, administrative segregation. All of those, I have to say that I've learned a lot through many, many mistakes. When I started in the New York City jails, incredibly high rates of solitary confinement. We also had adolescents in our jail system, and when I started, 25% of the kids were in solitary at any one moment. And about 8% of people experience solitary. So during any time as adults, so very high use reliance. In eliminating it, we've worked on identifying the harms, which weren't hard to do. That wasn't hard to do, to get data out there. I think that one of the things that we struggled with, and most places struggle with, is that correctional staff have learned to do things a certain way. And beating and solitary confinement are two things that are perceived as tools by custodial staff sometimes, not always, but sometimes. So when you try and go after those practices, you have to have built support for other things that are also perceived as tools. So for us, CIT, Crisis Intervention Team, training, and also developing therapeutic units and getting the funding for those units is critical. We didn't get that all done at the same time. And so a lot of acrimony and also a lot of bad outcomes flowed from the fact that we went after the bad practices without having all of the new practices and support for them in place. And I've both seen it, I felt it, our patients have felt it, the correctional and health staff also. It's very difficult, and depending on how ingrained the practices are that you're going after, it does take a really concerted effort to understand what are the principles that everybody's operating under, and do we agree on what the principles going forward are going to be. That almost never happens.
So I think I want to get into the weeds on Medicaid. So each of you have touched on sort of different aspects of thinking about using Medicaid in some capacity for correctional healthcare. I would say maybe you'll disagree with this, but I feel like over the last, say, 5 years, when issues of Medicaid and correctional health have come up, the conversation's sort of been at the level of hey, think about Medicaid, and maybe there's a way to use Medicaid to improve this system a little bit. And now we're sort of at this transition point, I would say, where there's a real chance that Medicaid's going to be used in some capacity to finance care in the not so distant future. And as that transition's happened, I've started to think a bit more deeply about what is this going to look like? And one of the things I think about is at our jail, 90% of the care is nurse driven. That is not a Medicaid reimbursable expense. And so if you were going to try to say finance jail healthcare just with provider dollars, that will not finance all of the nursing care. And so I'm really curious, I guess, maybe you all have it figured out already, but if not, what are some of these nuances that you're thinking about that you think maybe are not being taken into consideration in the current national discussion, and sort of details that really need to be flushed out to make Medicaid work for jails and prisons?
Yeah, that's a great question, Tyler. One of the reasons why, Medicaid keeps coming up is because multiple people see it as a potential avenue. The challenge is jail health standards. And how are we going to measure jail health care standards across the board? If we're going to have, a single payer system like Medicaid cover these services, Medicaid is not going to want to cover suboptimal care. So we need to ensure that these facilities are providing care that CMS thinks is worth paying for. And that's one of the reasons why we're likely seeing a lot of delays with having Medicaid pay for these services. The 1115 waivers that I mentioned, those have been, sitting around CMS for quite some time. And what we're hearing is that CMS is trying to figure out the jail healthcare standards. One of the other speakers mentioned the challenges with data reporting. If Medicaid is going to pay for these services, then the facilities are going to need to figure out how to report back to Medicaid that they have provided this care and that the care was adequate. We all know, for those of us who work in jails and prisons, evaluation, data collection is a challenge, particularly for a lot of our smaller jails. Some of the technical assistance that my team is providing currently, folks are using paper and pencil for medical records. How do you move a jail from paper and pencil medical records to doing data reporting that is going to be necessary for Medicaid billing and reporting to Medicaid that you provided adequate care to a patient? So there's a whole host of things that need to be sorted out. And Medicaid is one potential avenue, but as I mentioned through some of the bills I mentioned, there needs to be some legislation that needs to be put into place to change what we currently have with the Social Security Act to even make that a possibility. Otherwise, we'll have to do it through 1115 waivers, which currently have not been approved.
There's a question in the chat. How would you recommend that those of us who work in academic and public service settings reach into our circular settings, either toward providers who work for private entities there or as advocates for individual patients we may see at one instance? And this was related to a chat question that was posed a little bit earlier about for those of us who work in places where there aren't transition clinics and other providers who are more knowledgeable about this topic, how we screen for our patients, whether in the emergency department where I work or in outpatient settings, in a way that's non-stigmatizing and that expresses that we do want to provide the best care we can, knowing the difficult circumstances behind bars. Maybe Emily, if you want to take that one.
Sure, I can start. Certainly, given kind of what we've discussed and given the gross, frank discrimination there is around criminal records and criminal records as they relate to all sorts of other social needs, employment, housing, this is not necessarily always something that a patient is interested in discussing. And so, I think first and foremost is that, in my own clinical practice, and often I do think it's important, is we of course don't have a standard of how we even discuss people with histories of incarceration. I appreciated Tyler kind of introducing this topic, is that there's language that is stigmatizing and how it is that you can use patient-centered language. So one is just involving our patients, those with histories of incarceration in this, like, how would you like your doctor to ask about it? Should it be recorded in the electronic health record? What are your rights? Like, where is it that you can kind of express and kind of say that it's none of your business what crime I committed? Why should I have to share that with you to get health care? Because of course, these are the sorts of types of questions that asking a history of incarceration, like within your HPI, can lead to without proper guidance. So I do typically screen patients, especially my own primary care practices among those that are transitioning home. But I would say even within the inpatient service, I do regularly ask it as part of the social history, and regularly ask it couched, recognizing, especially if it's tied to, hey, they're presenting with an opioid use disorder, in that context. It's like, people that have passed in jails and prisons have kind of higher rates. And so I'm asking these questions. And I typically ask, have you or any members of your family ever spent time in a prison, jail, or detention center? And so it broadens the language out. It doesn't point them out in any particular way. And it really screens also for family exposure to incarceration, which is quite high, has bearings for, kids, parents, those who've been incarcerated. Oftentimes grandparents will then start sharing with us really important things, that their kids are incarcerated right now and they have kind of difficult financial burdens, et cetera, and taking care of their patients, and so have not been able to attend to their own health. And so that's how I screen for it. I have to say that it's not a perfect practice, but it's something that I think, again, given how highly prevalent it is, how much the prisons and jails place our patients at risk for poor health outcomes, especially in the transitions, that I think it's of critical importance. I mean, how many times do you think that in our primary care practice, when people have been out of care, and especially depending on where you practice, maybe they're out of your care, but they're in somebody else's care. And without our understanding, and again, as y'all have alluded to, we rarely get training in this. If we don't ask, we won't know. So that's how I ask. I think as far as what Joseph Boyle is asking, I think some of it is like, to me, some of my first time in a prison or jail was critical. It's just to step foot, reach out, go in there, see what it's like, introduce yourself to the colleague. If you have a patient that, presents to, your emergency department shackled, that person has a doctor. Reach in, talk to them, see if there's a way that you can kind of start creating those relationships, because that also, I think, are ways that, we start building the connections, again, not operating within siloed health systems. And it's in that, especially if you're in an educational role or leadership role or in your own primary care practice, that you can both also, I've had great conversations with providers inside that are doing their best, not as great conversations with the providers that actually do not know what they're doing. But it's in that within kind of at least our provider communities to really discuss what quality of care looks like for us here, how it is that we can facilitate communication. The other thing I would mention is that oftentimes for these same patients, it's the providers who are practicing behind bars that are like wondering, what is going on? Like, how come we can't get records inside? So there is this bi-directional problem. And that is in large part the problem, is because, again, the systems are so intentionally siloed. The health outcomes are terrible. And we kind of just are like, well, they're incarcerated. Oh, well.
Any other comments from the other panelists on that question? All right, we have 5 minutes left, so I'll ask one more question. Let me just find it here. I think the question was something along the lines of, many of our patients are going to, as Dr. Wong mentioned, have their first healthcare experience while they're incarcerated. And how can primary care doctors in the community sort of think about caring for someone who the only other healthcare they've had was in a jail or a prison setting, and what might be tools for a clinician to engage that person in care in the community? what I think about often is, I'd say most of the patients we see, it's the jail settings the first time they've ever received medication for opioid use disorder. So that's sort of, I think, a very top of mind example for me, but certainly there are many people who it's the first time they've received metformin or a variety of other medications for their chronic disease. How can clinicians welcome people into their practice, and what are some pearls for clinicians to help their patients with their first community healthcare experience?
I'll start by just saying is like, I do think just the very point of asking and recognizing that that's the case. I mean, for those of us that have stepped foot in a prison and jail and knowing how truly different the practice of medicine is and the experience of healthcare is, a lot of the assumptions that we make about kind of what a patient ought to be able to do are just off. They never had to go to a pharmacy to get their meds. They've been inside for 14 days, 20 years. That's not a practice that you have. They don't know how to time their medication, how to drop insulin, as I mentioned, how to navigate, picking up a pharmacy, going to the chest x-ray. They're escorted everywhere. And so, it's because we're hurried as primary care doctors too. What's hard is that we're stretched thin often in a primary care practice to get this done in 15 minutes. But I think it's important to know is that that first visit with the person that's just come home from incarceration isn't going to take you 15 minutes. Like it's a flawed assumption to think that they're going to go in there, get through their meds, get their refills, and then just know how to do it and move forward. And so part of what I think is realizing that, in that first visit, probably one of the things that I think is most important is just welcoming a person home and saying that this is a place that we will work to earn your trust over time. To me, there's a real quick and hurry about what it is that we have to do. We got to get the meds refilled and got to get them. Oh my gosh, you don't have a colonoscopy. No, I'm going to get all these. And to me, much of the work that we have to do for primary care is really just that first step of saying, welcome home. We know you've come home, and that's a totally different experience of healthcare. And we'll work to earn your trust, and that's going to take time. So what are your needs? And then starting from there. To me, I think that that's the kind of critical piece is that without knowing, you make assumptions about the person and kind of their own adherence or compliance or how it is that they navigate the healthcare system. And much of these are learned behaviors that I think promote survival behind bars.
Wonderful. Thank you. Well, we are at time. So I just want to thank our panelists so much for joining us today. I hope that everyone enjoyed it as much as I did. It was a real treat to learn from you all today. And thank you to all the attendees who were able to join us today as well. I think that concludes our webinar.
Thanks, everyone.